everyone, good morning and welcome to our webinar on diagnosis and management of osteoarthritis and large joint trauma in partnership with St George Hospital. My name is Lauren Thomas and I'm CPD Program Officer here at CESPN. I would firstly like to start acknowledging the traditional custodians and sovereign people of the land across which we work. We recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. We also extend that respect to any Aboriginal colleagues who may be joining us today. I would now just like to introduce our speakers for today. So we have Associate Professor Justin Paolono, Sports and Exercise Medicine Physician, Associate Professor Allan Sturgess, Associate Professor of Rheumatology and the Department Head at St George Hospital. We also have Kylie Turner, who's the Chronic Kidney Disease CNC at St George Hospital. She will also be facilitating the Q&A for us. And at the end, we'll also be joined by Dr. Martina Gleeson, who will be doing health pathways for us.
Okay, so my name's Justin Paolono. I'm a sports physician at COGRA. I'm not sure who all the audience is, so I may have met some of you and I may not have. We've been around the area for quite some time. But today we'll talk about large joint dislocations. We'll try and keep this as practical as possible. So to go through, we'll look at most of the large joints, and I've put the asterisk next to the ones I'm going to spend most time on because these are the most amenable to out of hospital or on-field relocation. And then we'll talk a little bit about what sports physicians do in patient care and I guess out of ED as well through referrals. So let's talk about shoulder first. This is probably one of the more common dislocations and one you may see in your daily life, even with people falling, not so much in your rooms, but falling around rooms, around sporting fields. The shoulder is a very mobile joint. I mean, we can move our shoulder, swing it around in multi directions, which we can't do with most of our other joints. The sacrifice of that mobility is it's not a particularly stable joint. With the glenoid and the humerus, it's about a 4:1 ratio. So the humeral head is 4 times as large as the glenoid. Some people call it like a golf ball on a tee or a seal balancing a ball on its nose. But essentially the principle is it's not particularly stable and it can fall off the glenoid quite easily. The shoulder is described as a muscle dependent joint because really the muscles control it. Our static constraints, as in those that control the shoulder when the muscles are not working, are not particularly strong. I mean, we do have the ligaments, we've got the biceps, but they're not particularly strong and can't keep the shoulder in the joint if there's any force applied while the muscles are relaxed. Just to show you again the rotator cuff and to appreciate that when the shoulder dislocates, it tears things. It tears the capsule, sometimes it also tears the rotator cuff, and of course we can get fractures as well. So 98% of shoulder dislocations are anterior, and you can see on the slide there that we've arrowed the Bankart lesion. So as the humeral head comes anteriorly out of the glenoid, it knocks off soft tissue always, and sometimes it knocks off the glenoid rim or the bone. So we can have soft tissue Bankarts or bony Bankarts. And you can see that once that bit of bone is chipped off, it's like there's a channel for the head to come out, and that's why redislocations are so common. There's no longer the chock under the wheel of the humeral head. The shoulder tends to dislocate in the throwing position or abduction, external rotation, because that's where the ball is as far forward in the socket as it can be without dislocating. And all it needs then is a little bit of anteriorly directed force and it comes out. So again, when the shoulder comes out, it always tears the capsule. We always get a soft tissue Bankart. We sometimes get a bony Bankart, and we can also get the Hill-Sachs lesion, which is the posterior-superior aspect of the humeral head. That tends to get a divot in it essentially, because as the ball goes in and as the ball goes out and comes back in, the posterior-superior aspect of the humeral head hits the glenoid and can cause a divot in the top of the humeral head. We can get other injuries, avulsion fractures where the rotator cuff pulls off, or sometimes surgical neck of humerus fractures. So when the shoulder is dislocated, what do we do? I mean, obviously we want to relocate the joint, but it's about when we should do this. Is it appropriate? where we should do it, and then how we should do it. Most people advocate a pre-reduction X-ray, which I think is reasonable in an acute care setting. Obviously, if you're by the side of the field or somewhere else where that isn't available, I wouldn't necessarily send to get one, and we'll talk about how to assess a shoulder and know whether you should send it to ED or whether you're comfortable to relocate. The real key is analgesia. Essentially, when the shoulder comes out, muscles start to spasm. So the quicker we can relocate the joint, the better, because the more muscle spasm there is, the more muscles are fighting you to traction and relocate the joint. I tend to use, actually we'll go into the analgesia later. The technique is less critical. I mean, there are many described ways. The Hippocratic method, so putting the foot into the armpit and pulling the arm. The Cocker method, where we traction the arm, externally rotate. There are other ones called modified slouch, where someone's sitting in a chair with another person holding them. They're leaning forward, so the person holding them is taking all of their weight and the muscles are relaxed. And then it's almost like a handshake, where you grab the hand, traction, and externally rotate the limb. That's the modified slouch. So essentially, we have to put traction and we have to put external rotation to relocate the mechanism of how it dislocated to allow the shoulder to go back in. Probably important to recognize is counter traction. A lot of people don't think enough about this because, you know, we get a bit stressed if we're not used to doing this. It's all very acute. It's all very scary. You know, sometimes the person's in pain. There's a lot of bystanders. It's important to take your time. You know, we don't have to pull it straight away. Take our time, get a good position, try and enlist someone to help you with counter traction, because if you're pulling on the limb and there's no resistance, all you're doing is pulling the limb and the body forward, and you're not going to relocate the joint. It is critical to get a post-reduction X-ray because we need to assess for fractures and, of course, that the joint is end-located. And then we'll do our basic things like sling, analgesia, rehabilitation. So just to look through a clinical scenario, I'll let you read that, but essentially, you know, we have a footballer who makes a tackle. He has severe shoulder pain. He's had a previous dislocation, so that's a bit of a key. And they've got an extremely painful shoulder when they present to your rooms. So we'll do this as a rooms-based one. So what do? Let's always think about the basics. We need to check the neurovascular status. That's critical so that we know with any dislocation, is there a threatened limb? You know, do we have a vascular injury? Do we have a nerve injury? But particularly vascular injury, because that's what threatens our limb, particularly with lower limb dislocations, and you know, it can lead to amputations with extremely delayed cases. It's important to expose the limb, and this is where it always gets a little bit tricky. You know, do you cut off the jersey, this kind of thing? I would. I just think for the sake of however much that jersey costs, you need to adequately expose the limb. It's very hard to get a jersey off a dislocated shoulder without cutting it. You can try if it's loose enough, but otherwise you're better off taking that off. When you have a look at the shoulder, what you'll notice is a fullness in the anterior shoulder, because in an anterior dislocation, the ball is sitting there in the front of the shoulder. I think it's worthwhile also inspecting the back of the shoulder, particularly the posterior corner of the acromion, because as the ball comes out anteriorly, it puckers the skin in posteriorly. And you'll often notice a little dimple where the skin is sort of pulled in at the posterior acromion, and that's a really good sign that the shoulder is anteriorly dislocated. Again, X-ray, if we're not comfortable saying this is definitely dislocated, we're going to relocate. If we are going to get an X-ray, I've put that little blue circle there to show you what the glenoid looks like and how small it is relative to the humeral head. So that's a lateral X-ray, and we're looking at the Y of the scapular inside profile. And so again, it'll depend. You can see the ribs on the left there. So if the head is anterior, it'll have gone to the right on that X-ray view. If it's posterior, it'll have gone to the left. It is critical again for analgesia. This will, to a degree, depend on your comfort. I would normally put an IV drip in and use intravenous morphine. Make sure you have Narcan on hand, but that I believe is the best way. If we've got time, we can't get a patient to ED because we're remote or somewhere else. But even so, that's appropriate analgesia just in case they need to go to surgery, because occasionally shoulders cannot be relocated except by surgery. if the head gets locked under the coracoid process, sorry, coronoid process, coracoid process, getting it right eventually. So once we've relocated the shoulder, and again, the method isn't so important. The important things are analgesia, traction, counter traction. When we traction with the shoulder, external rotation as well. Then we do a post-reduction X-ray. But after they've been reduced, what do we do? So they probably want a sling for comfort and to prevent redislocation in the short term. Analgesia is appropriate in the first couple of days and probably just needs to be oral. Maybe think about anti-inflammatories as well, because we know there's capsular damage. And then ultimately, the treatment is muscular rehabilitation. We have to get those muscles back and controlling the joint, and that's mainly a rotator cuff strengthening program. In young people with first dislocations, there is a very high rate of redislocation. It's about 95% within 2 years if they go back to contact sport. So surgery is appropriate with a first-time young dislocator. However, it's very difficult to convince a patient to go and have surgery when they've only had one dislocation. It doesn't mean we shouldn't try, doesn't mean we shouldn't send them to a surgeon, but a lot of people say, look, I'll wait and see how it goes. Of course, 95% will redislocate, and then they're more convinced. The problem with that is they may do other injuries when they redislocate. Just to check you're all still awake. I don't know how many people are trained at Little Bay where that shark attack was down at Prince Henry Hospital, but I used to live down there and swam there regularly, but glad I didn't see this one. Okay, so let's move on to elbow. So on this X-ray, I've just put those lines there to emphasize that this is a hinge type joint. So the elbow bends forward and backwards. It does not have a lot of lateral or medial movement. We can see the coronoid process at the front, just underneath the radial head in lateral. And as the elbow dislocates posteriorly, it tends to knock off the coronoid process. And it's important because in post-reduction X-rays, we need to assess how much of the coronoid process of the ulna was knocked off to work out whether it requires surgery or whether we can treat it non-surgically. So the majority of elbow dislocations are posterior and generally with falls onto the outstretched arm, driving the forearm posteriorly and knocking the elbow out of joint, also injuring that coronoid process. With the elbow, we almost always get lateral collateral ligament injuries and medial collateral ligament injuries, and we'll talk about those after. It's common to knock off the coronoid process, and remember that we have our ulnar nerve in the cubital groove. That's important with relocation. So again, what do we do if an elbow is dislocated? Obviously, again, we want to relocate the joint. We check our neurovascular status. Again, depending on your access of X-ray, you know, it's always going to be advocated in the books because that's the right thing to do. Check you don't have other fractures, etc., etc. In reality, it's pretty obvious when an elbow is dislocated. I've relocated at least 4 on the sporting field, some in a professional capacity, some just when I'm playing social soccer. It's a surprisingly common injury, very obvious when the elbow is dislocated, and really it's quite an easy relocation. But again, if it's early, it's very easy. You don't need analgesia. If they fall down next to you and you can see that it's dislocated, it's quite easy to put back in. The joint wants to go back in, but we need counter traction. So we need to enlist someone to hold the upper arm while we're pulling the lower arm to relocate. We need to get that post-reduction X-ray, especially to look at the coronoid process, but there are other fractures, radial head, olecranon process that can occur. And then similar to shoulder, sling just to protect the arm, some oral analgesia, and we're going to talk about rehabilitation. So with our clinical scenario, footballer falls on the outstretched limb, severe elbow pain, disability, they can't play on, they think they've dislocated their elbow, so what do we do? I'll just check the time. Okay. So neurovascular status is critical. We need to check that, particularly ulnar nerve function. We expose the limb. If we have the capability, we do a lateral X-ray to check for fractures. analgesia or early reduction, which is a straight pull on the elbow. Again, it wants to go back in. One of the complications of relocating elbows is that you can get entrapment of the ulnar nerve in the joint. There is nothing that you can do or not do that makes that happen or not happen, but it can occur. So be aware of it and definitely test ulnar nerve function afterwards. I've seen that once in a hospital setting, a trapped ulnar nerve, and that requires surgery if it occurs. People used to describe techniques of trying to keep the elbow in valgus varus and as they traction, but it really makes no difference. So elbows, despite the fact that they tear the ligaments and should be unstable, actually tend not to be too bad, and they only need a brace for a short while. Elbows have a particular propensity to become stiff if we immobilize for too long, so we don't want to put them in a sling for too long, just for comfort, and then we can reassess the ligaments or send them on to a specialist. They do need muscular rehabilitation to try and prevent redislocation, and if there are large fractures, particularly more than 50% of the coronoid process, they may require surgery, or if for recurrent instability, the elbow just keeps popping out because it doesn't have a congruent surface, which again is mainly because of the coronoid process. And I've seen it again where you relocate a joint, it just pops back out. So if it's unstable, it's unstable. You probably just need to put in a sling and get it to a major center. Okay, I'll just talk very briefly about hip. Hip dislocations, take a lot of force, motor vehicle accidents, rugby league, things where you get a lot of force because it's such a deep, strong joint. Very hard to relocate in the out of hospital setting, so we might pass over this. But the important thing is, unfortunately, it's cut off this slide. The risk of sciatic nerve damage is directly proportional to the length of time that the hip is dislocated. And they talk about 4 hours being the magic number where we really need to be getting the hip in within 4 hours. So in many cases, it'd be straight to hospital and get them to relocate. So we'll go into knee joint. The knee is basically a hinge. Again, with the X-ray, you can see that it's not a particularly congruent, stable joint. It's not deeply end-located. And whilst anterior or posterior knee dislocations happen, there's something that generally would be relocated in a hospital setting rather than in an out-of-care setting. So we'll talk a little bit more about a patellofemoral dislocation, and I'll put the blue thing there just to remind you how unstable the patella is. So we can see on the AP where it sits on the lateral with the knee in extension. It's very, very loose. We can move it mediolaterally pretty easily by grasping it and putting it side to side. So we'll talk about this is about anterior and posterior knee dislocations first, so not patellofemoral, because it's important to recognize that whilst we don't really want to relocate this joint if we can avoid it, sometimes the limb is threatened, so we have to check our neurovascular status. If there's a vascular injury, popliteal artery injury, something, there's no pulse, there's no sensation, there's no peripheral return, dusky coloration, the limb is threatened, really, we're better off trying to relocate it than not. And normally that's a bit of traction and a straight pull, either anterior or posteriorly, depending on the direction of knee joint dislocation. But generally, otherwise, you'd be getting it to hospital. So let's talk about a more realistic relocation. The patella, which is common, and many of you will have seen this, it's common in adolescents, young adults, particularly females, can be associated with generalized ligamentous laxity, where people have loose ligaments, can do all the tricks like bending the thumb back and little finger and double jointed elbows, etc. Remember also that with patella dislocation, we often get a hemarthrosis. So the knee is full of blood, and that's got importance as in what we do post-care. So again, with the clinical scenario, it's normally pretty obvious with a patella dislocation that it is dislocated. Remember that it tends to always go away from the midline. So whether it's a right or left knee, it goes laterally, so always away from the midline, and tears the medial patellofemoral ligament as it goes out. So we can examine the knee. Probably the best test is apprehension test. And again, it might be obvious the kneecap's out. If it's not because of swelling, to grasp the kneecap and to pull it laterally will make the patient experience pain, but also the feeling that it's more unstable. Again, the patella wants to come back into place. and with simple knee extension. So as simple as getting the patient to extend the knee or helping them to extend the kneecap will come back into place, because as we go into extension, there's a lot of looseness in there. When it's flexed, it's deep in the trochlear groove of the femur, and you won't be able to relocate it. You've probably all seen pictures of footballers. I've seen videos of an AFL footballer sitting on the ground, knocking it with his hands, like literally trying to knock it back in, which does work, but you tend to get the patella fractures or the lateral femoral condyle fractures because you're forcing it over or through the bone. Important to give analgesia. Very important to control the swelling, because with rehab, the muscles get inhibited by the swelling and the hemarthrosis, and sometimes it's worth considering aspirating the joint if there is a tense hemarthrosis. Sometimes you can get up to 150, 200 mils of fluid out, and that really helps with the rehab, but also helps the patient's pain. They may require crutches, so again, protecting the joint, much like the upper limb with a sling. Do we need a brace? Do we need crutches? Generally not a brace, but crutches if it's painful. And then the rehab versus surgery is a little bit complex, but essentially we always tear that medial patellofemoral ligament when the patella is dislocated. We can rehab, but we can't make that any tighter. So sometimes if it's torn too much and the patella is too lateral, it'll just keep coming out. So we need to go to surgery. Just to check we're all still awake, and how's my time? Probably getting close. Okay. Sorry, Lauren, stop me when I'm getting close, but we'll keep moving for now. So we'll go on to the ankle. And you can see from these MRIs, why I put them here was, firstly, on the one on the left, you can see that the talus sits in the mortise, which is made up of the tibia and the fibula, and a little blue square of the syndesmosis, which has three parts: front, back, and between the bones, or interosseous. And that controls the mortise shape so that the ankle is congruent. Dislocation does take a bit of trauma, but is relatively common. Unfortunately, with ankle dislocation, you almost always get a fracture. Sometimes you also get a diastasis or a separation of the syndesmosis. Why those two things are important is because we lose the congruence of the ankle mortise, and we really need to put that back together, often surgically, sometimes with bracing. I'll just use my model to show you here. So this is a right ankle. This is our syndesmosis. But why I wanted to show you was, as the foot tends to be in dorsiflexion and we externally rotate, you can see that it widens the mortise widens the syndesmosis at the front. You can tear the front, the interosseous the back. As it rotates, it knocks off the posterior malleolus of the tibia, and then it can also cause any of the Weber ABC fractures. But up near the knee, we can get a major nerve fracture of the fibula, which is a spiral fracture because we're twisting the fibula, and at the proximal end, we get a fracture. So make sure that if there's pain around the knee, we're assessing that, including with X-ray. So that's all part of a pattern of injury, and it's probably more important with the ankle dislocation than with most other joint dislocations. So if we see this, and you can see the MRI, the separation between the two bones with the fluid. So this is a diastasis because we've got a complete separation. And often with that, the patient may not be able to weight bear, but surprisingly, even with complete diastasis, sometimes there's minimal pain, the patient can weight bear. Ankles are one of those joints where clinically and on X-ray, they vary a fair bit. Sometimes people look like they've no injury, they have terrible injuries. Sometimes they look vice versa. Okay, so we want to have a look at the ankle. Remember our Ottawa ankle rules about when we X-ray, when we don't. So the bottom 6 centimeters of the posterior, medial, and lateral malleolus. If there's tenderness there, we need to be X-raying. Mainly begin because we're looking for diastasis and Weber fractures. And then if there's tenderness over the navicular or the base of 5th metatarsal, we do a foot X-ray to rule out fractures in those regions. So analgesia, crutches. Now here's the thing that is difficult with syndesmosis injury. If it's a complete diastasis, really it's going to need surgery, and often there's a fracture, so it's a bit of a no-brainer anyway. So that's to the orthopedic surgeons. If it's a grade 1 or 2, often bracing. Particularly with air cast stirrup type bracing, which just squeezes the tibia and the fibula together to hold the to hold the syndesmosis in place to allow it to heal. Often that's all we need. but that needs a bit more specialist management by someone like myself. If you're comfortable doing it, that's fine, but otherwise that's one where we can help. So hopefully we've gained some information, and obviously we've got a chance for questions later, but just to, most people will know what sports physicians do, but basically we do the non-surgical management of musculoskeletal injury. If there are difficulties with diagnosis, very happy to help with that. And obviously with treatment, rehab, injections, aspirations, sometimes orthotic prescription, depending on the injury, and simple fracture management. So I'm sure you're all aware of this with our hospital system and then our specialists. So if it's surgical, it's the orthopods. If it's non-surgical, sports physicians. So interestingly, a lot of post-dislocation management is done by sports physicians rather than orthopedic surgeons, but there are indications to send to orthopods, particularly with certain type of fractures or recurrent instability. Thank you.
Look, thank you so much for inviting us. I mean, Justin and I were really delighted to help out with the Primary Health Network training program. So look, so I'm going to be talking about osteoarthritis. And mostly the principles, I mean, I'll talk about various joints, but the principles are pretty much the same, depending on, regardless of which joint it is. So let's start with what those principles are. We'll start with, what causes osteoarthritis, and have to admit, like, some of it is still unknown. Age is certainly a factor. I mean, it's a disease that's more common as we age, but there's a wide range. So you can see people in their 40s have got osteoarthritis, people in their 80s who don't. So age is a factor. Trauma is certainly also important, and that's, say, congenitally abnormal joints or injuries that you've acquired through life. The classic one is an injury that leads to a meniscectomy. Remembering, we think it's the injury that is the cause of the osteoarthritis. The meniscectomy was like a bystander. There are a handful of genetic syndromes that have names, like Stickler syndrome. They're usually people who do look a bit odd. They're intellectually normal, but have an odd-looking face. They're very myopic, and they get premature osteoarthritis. But most people with apparently genetic OA, we can't say what's wrong with them. They give us a strong family history, but we're unable to identify the gene yet. Obesity is a major factor. Oddly enough, it's a major factor for weight-bearing knees, joints like the knee, which is sort of obvious, but seems to also be a factor in non-weight-bearing joints like the hand. People who've got chronic pyrophosphate arthritis, so this is different to an acute episode of pseudogout, like in the knee or the wrist. We think an acute episode that you might get once or twice in a lifetime, probably that's not a cause of osteoarthritis, but people with like a chronic pyrophosphate arthritis, that's a variant of osteoarthritis. And it's obviously, if someone's had rheumatoid arthritis, it's then burned out, they often then have ongoing osteoarthritis after that. The principle, I guess this is the most important slide. In fact, if you didn't remember any other slide, this is the number one. Firstly, osteoarthritis, virtually universal. I think that most of us, speakers and audience today, probably have some osteoarthritis. And as yet, despite enormous effort, there are no drugs that alter the underlying process. Unlike rheumatoid arthritis, where we have many disease-modifying drugs, methotrexate, leflunomide, slazopirin, all those drugs that modify the course of the disease, we don't think we have any drugs that modify the course of osteoarthritis. Radiology and symptoms have a very poor correlation. I mean, there's some correlation, of course, but you can have terrible joints on radiology and very few symptoms. Physical therapy, this is the most important line of the most important slide. Physical therapy is way the best treatment, much more important than any sort of drugs. And surgery, we can't do surgery for every single person who's got osteoarthritis. There's a role for some drugs that I'll talk about, and there are some drugs that I think should be used very, very rarely. So just to emphasize some of those points, just the fact that you've seen osteoarthritis on an imaging or it's been reported doesn't mean that that's the cause of the pain. And that's a real trap. An X-ray that says OA, but the pain is something else. So we'll talk a bit about that. On the drug line, well, I'm emphasizing we don't have disease-modifying drugs. There's no allopurinol like there is for gout. And many, many drugs have tried and failed. Chondroitin, glucosamine, krill oil, platelet-rich plasma, stem cells, Now, I might be almost excessively conservative in this matter, but I think most of the time stem cells are a scam. And a lot of patients lost a lot of money having stem cells injected into joints. I emphasize that radiology and symptoms don't match. You can have very advanced osteoarthritis on X-ray and have no symptoms, or you can have a lot of symptoms with X-rays that aren't that exciting. Now, physical therapy, by that I was meaning exercise, sometimes exercise directed by a physiotherapist or enthusiastic sports physician, someone who can really motivate the patient to do exercise. Because let's face it, not many of us like exercising. It's got to be something that we enjoy doing, that we want to do, that we're going to do every day. Muscle strengthening, muscle balancing. The drugs for which there is some role are non-steroidals and paracetamol. I try to use those as needed, not every day. And as you know, probably, I don't know, the majority of the people I see have contraindications to non-steroidals. Seems like every Australian's got renal impairment, hypertension, they're on a blood thinner. There's always some reason why you can't give a non-steroidal. So and nearly always it's as needed. And last one, the drugs that I think should very, very rarely be used. I try never to give opioids. I have a particular dislike for Tramadol and Palexia because I think you're trying to fool yourself that you're not giving an opioid, but you are, and you're giving opioids that have weird side effects, as well as the ordinary stuff, drowsiness and constipation, a lot of drug interactions, serotonin syndromes and things. So I think I would try very hard never to use those. And as for Lyrica and Neurontin, they're scams. Those two drugs, there are limited indications for those. Painful diabetic neuropathies, herpes zoster, pain on the face. But otherwise, I always tell my students, once you start to use those drugs, it always ends in tears. So osteoarthritis of the hands, just about everybody's got it. Like Heberden's nodes, Bouchard's nodes, OA at the base of the thumb. So here's a woman with osteoarthritis at the base of her thumb, the so-called squaring of the thumb. And here's a chap who's got osteoarthritis in his DIP, and he's got a mucus cyst, which is a kind of a ganglion that comes out of the DIP joint. Now, I can tell you, I didn't have to look very far to find these photographs. The hand belongs to my wife, and the finger belongs to me. Neither of us, take medications. We just, our parents had these things, and we thought, well, this is the price of life. So we both are pretty energetic. We play tennis, we go bushwalking, and occasionally our joints hurt, and we might take some paracetamol, and we keep exercising. What can you do for osteoarthritis of the hands? Well, I think a heck of a lot. People come to see their doctor to be explained what's wrong. They don't necessarily think we can fix everything. So for osteoarthritis of the hands, I explain that it's a common issue as we age. I stress to them it's not a destructive, crippling arthritis. They might have, and I try to separate, say, rheumatoid arthritis from osteoarthritis. I educate the patient that the symptoms vary. They'll have periods where they have a flare-up where all their joints hurt, and then they'll have periods of remission virtually. The lumps don't go away, the Heberden and Bouchard's nodes, but they become less painful. I stress that the best thing to do is keep up all your activities. You might make an occasional adjustment. So if you had somebody who was an enthusiastic gardener, like my mother was, instead of gardening for hours and hours every afternoon, but we got our mother to use it for short periods of time and heavy work, like heavy secateurs. We came up with a rough rule for my mother that if the branch was more than 1/4 inch thick, she should get someone else to cut those ones for her because it was bad for her thumb. Exercise physio, that's way the most important thing. That is the big thing of osteoarthritis. The drugs used as needed, certainly not every day. And I've mentioned there, I would tend to go for, COX-2 type drugs, Celebrex, Mobic, or straight paracetamol. In terms of steroid injections, I think there is a place for them at the base of the thumb, but it would only usually be if people had quite a long period of pain. It didn't seem to be settling. I'd explain to the patient it's not a long-term treatment. In fact, in the long run, it's probably likely that steroid injections do accelerate osteoarthritis. So it would be not frequent. And I never try to inject a Bouchard or Heberden's node. I mean, you'd be flat out ever trying to get a needle into that joint. Now, topical non-steroidals do help. Look, I have to be honest, I haven't had much success with them. I often recommend them, and I particularly do that if the patient can't take a non-steroidal because they're on, apixaban or Eliquis or warfarin, or they've got chronic renal impairment. There is a role for splints. There certainly is a role, but gee, they're awkward, with ordinary life, washing your hands. So that's a nice thumb splint, and I often send people to hand therapists. And the patient sometimes tells me, look, I wear it, doctor, when it's really bad. I wear it, I take some paracetamol or I take 2 Celebrex and I wear this splint for a day or two, but it's not practical because I've got to wash my hands and do ordinary life. So it's not a long-term strategy. Osteoarthritis of the knee, a couple of things I especially wanted to stress here. Now, I put that image up in the top right-hand corner, which I might go to that one first. So first, you look at the radiology, and the woman says pain's in her right knee. Left knee doesn't worry her. Though the left knee, you can see there is narrowing of the joint space on the medial side, but it's bone on the right-hand side. So when you first look at the x-rays, you think, okay, person's got osteoarthritis of the medial compartment on x-ray, but we'll come back to the symptoms. Everybody gets OA, I think it's universal, but not everybody gets pain or disability. And the x-ray changes correlate very poorly with the symptoms. Sometimes the most dramatic signs come from the patellofemoral joint. Particularly women, even quite young women, can get dramatic crepitus. They can hear it when they're walking up and down stairs. But they need to hear from their doctor that, oh yes, you can get such a lot of creaking signs, but it's not the part of the knee that's taking your body weight. We can manage it, and sometimes the noise is out of all proportion to the pain. So I've underlined that the best treatment for knee OA is exercise, especially quadriceps strengthening. Knee supports, I'll talk about that in a sec, they do help, but long run, you got to get strong quadriceps. You got to get and balanced quadriceps. I do believe in taping for patellofemoral pain. I don't think all physios are good at it, and some you really have to specially ask them. And I usually tell the patient, I don't see them wearing taping on their knee for a lifetime. This is while they strengthen their own muscles and pull that patellofemoral joint into its right alignment. And I always tell patients that drugs don't replace quadriceps strengthening, but they occasionally help. I've written there, rare steroid injections can help, but the only people that I would regularly inject are people who are too old or too frail or have other comorbidities that mean they can never come to knee replacement surgery. I think once a patient is looking at multiple steroid injections with short periods of relief, that's an indication for surgery. So a small number of people who have osteoarthritis in the knee, I should say a small proportion, of course, in a population of almost 30 million people, many of whom are overweight and unfit and have poor quadriceps. An awful lot of Australians come to knee replacement surgery, but it ought to be a small proportion of those with OA. And look, a knee replacement has wonderful result. If the diagnosis is right, if that's what the cause of the pain is, OA, and if there are no particularly psychological comorbidities, people in chronic pain, people who are on opioids, people who don't do their rehabilitation, people who have pain everywhere or who catastrophize their pain, those people don't do well. That everything can look right with a knee replacement, but they're still in pain. So I think surgeons are getting quite cautious about people where there's a major misalignment of the symptoms and the x-ray. So this on the right is just those little elastic ones that you can buy at the chemist. And I do tend to use those short term. I tell the patient that it's not as though they are pulling the knee into the right alignment or anything, that what they're probably doing is giving you extra feedback, because when you bend your knee, the tightness of the elastic gives a lot of proprioceptive feedback. So that it's a way of teaching the patient where their knee is in space. And I'm telling them they're wearing that while they do their quadriceps exercises under supervision. A more complex one, like the one on the right, a hinge thing. Yep, look, certainly in trials, this can unload one side of the joint. That would be something that a sports physician or an orthopedic surgeon would do. I wouldn't usually prescribe those myself, or I haven't. But coming back to that person with the funny knee, that point, which is true in all of medicine, that the investigations and the history and the x-ray, they've got to match. So this person that I talked about, they certainly have gross changes of osteoarthritis on the medial aspect of the knee. But the patient says, well, this is where my pain is. It's laterally. In fact, you could almost put your finger on it around the sort of the upper part of the tibia, around this fibular joint here. And the patient was very good. And of course, you got to ask people where the pain is. You got to say, where does it hurt? So I don't think, she wasn't behaving as though she had osteoarthritis of the knee. So why is she got pain? Well, I have to be honest, haven't sorted it out. But this is her MRI. So here you can certainly see there's some fluid here and there's damage to the cartilage of the medial compartment. But here where the pain is, she's got lots of nice cartilage. On this image here, this T2 image, this white stuff is edema. So there's an inflammatory process here on the lateral side of the knee, just where she says her pain is. I have to admit, I'm not quite sure what she's got yet. Maybe it's iliotibial bursitis, or the radiologist thought that there might be some rectus femoris tendonitis. I don't think we've quite worked out what her pain is yet, but what it is, it's not going to get fixed with a knee replacement. So her radiology showing OA is not her problem. The hip. Now with the hip, it's even more important to stress when the patient says the word hip, what do they mean? You've got to make sure it is the hip. So I always ask the patient, look, can you show me where is the pain? Can you kind of point to it? And if it's too vague, I said, look, maybe just with the finger, show me where it's worst. And if the person is indicating, I've got pain on the outer side, with the lateral side of the hip, as you well know, we're more often thinking there that it's going to be a gluteus medius tendonitis, or what we used to call greater trochanteric bursitis. Or if it's very vague and there's a sensation of burning discomfort, maybe it's not musculoskeletal, or maybe it's neurologic. Maybe she's got neuralgia paresthetica, lateral cutaneous nerve of the thigh. So that can be a trap. Or maybe it's a radiculopathy. Maybe they've got a high lumbar thing and it's pain referred across onto the thigh. The patient might, when they use the word hip, they might mean the posterior part, like what we would call the buttock. So around the buttock area, lots of causes of pain there. Maybe it is musculoskeletal, like sacroiliitis, or maybe it's referred from the spine, or maybe there's some other process, a piriformis or something. So the posterior area of the, we would call the buttock, is often not the hip at all. So we like osteoarthritis of the hip. I like it to be in the anterior pain. The patient indicates I've got pain in my groin going down into my upper anterior thigh. That could be hip pain, but it could be a hernia, or it could be iliopsoas tendonitis. You wouldn't want to make a mistake and say the person had osteoarthritis of the hip and follow a protocol for treating OA hip if it's not OA of the hip. So here's a good example. This woman presented, and she brought her x-rays. I took a screenshot from her CT. So her right hip doesn't look too bad. Her left hip, there's sclerotic bone there. There's loss of cartilage. Radiologically, she's got osteoarthritis of the left hip. But when you moved her hip, and you could move her hip through a full range of motion, there was no pain. And she was particularly, like she was saying, it's not lateral, it's not my groin, it's around in the buttock. So that made me think she didn't really have pain coming from this radiology. What she's got here is another screenshot. This is her sacroiliac joints here, and here's an insufficiency fracture running through the part of the sacrum. So her pain's coming from an insufficiency fracture of her sacrum. So she does have osteoarthritis of the hip, and maybe one day she'll get a lot of pain in the groin, but that's not the problem at the moment. So she's not going to be helped by hip replacement surgery. She needs this investigated, why she developed a sacral insufficiency fracture. But if you're sure that it is OA of the hip, again, exercise is the best treatment. I've used that phrase there, that you need kind of a hands-on, almost charismatic physio, someone who really motivate you. And I suspect Justin's picked up a lot of clues along the top, around his course, about how you motivate people. Sportsmen are obviously driven people themselves, but trying to motivate someone who's not been active, that's a real challenge. And one little thing I've written here, if your physio uses a lot of gadgets, get a new physio. If the patient says, I went to see physio, really nice young lady, she hooked me up to a TENS machine or an ultrasound, and then she went next door to see someone else, that's not going to do the patient any good. No matter how much they enjoy having TENS, they're not going to get better. It's only exercise, only doing stuff gets you better. So Non-steroidals and Panadol help, but as I said, they're PRN drugs, and so many patients have contraindications. I made that point again, don't use narcotics. Once you start to use narcotics, which I include Tramal, Palexia, and the sort of wannabe ones, the Lyricas thing, patient will never be able to stop. They'll be addicted to it. It always ends in tears. Anybody who needs narcotics for an osteoarthritic joint, either there's another problem, a psychological issue, or they've got a really bad joint that needs surgery. And gee, let's face it, hip replacement surgery is a fabulous operation. Probably a few people listening have had it. So lastly, spondylosis isn't exactly osteoarthritis. It's a different process probably, but it's probably the same principles. So the principles of treating spondylosis, cervical, thoracic, particularly lumbar spondylosis, are the same. And the key thing is that the X-rays and the symptoms don't match very closely. That exercise is the best treatment. And I'll take this example. This is an X-ray and a bone scan for a patient with thoracic pain. And you can see here on the radiology images, big osteophytes. On the bone scan, they're hot. Big osteophytes, particularly on the right-hand side, you notice. This is thought to be that pulsations of the descending aorta on the left, in some way impede these. We believe this to be true because people who've got situs inversus and have the aorta going down the right-hand side of the spine, they get these kind of osteophytes on the left. And so now this is me, so no great revelation there. Just like got some osteoarthritis in my fingers, I've got it in my back. And I'm doing fine. I do my exercises. I go to a good physio. He kind of really pushes me along to do things. He realizes he's not going to turn me into an athlete. But by following the exercise that I prescribe, I don't use medications. If my pain gets worse, I increase the amount of exercise I'm doing. So that is the end. Excellent. Leaving a bit of time for questions.
I have one slide for everybody today, and it's just a link to our Southeastern Sydney Health Pathways site with the logins there on the left, and a reminder that if you can't find what you're looking for on our Health Pathways site, the Sydney Health Pathways site is also available with the same login details for you. We don't have orthopedic health pathways developed yet, but we do have a suite of rheumatology pathways that are available for you to see, including one on osteoarthritis, also inflammatory arthritis, septic arthritis, polymyalgia rheumatica, giant cell arteritis, gout, and the ever important requests pathway, which helps you identify private and public options for referral into rheumatology services in the Southeastern Sydney district. So how to access that public hospital outpatients department if your patient doesn't have the means to see someone privately, and also how to identify private people in practice. So I would encourage you to have a look at them, and when you're facing something that you feel like you might need an aid memoir or a bit of a memory jog to make sure that you're covering all of the things that you want to cover. We're also in the process of starting a review of our rheumatology pathways. So any GPs who use our pathways who have suggestions for how we might improve them, or even words of appreciation that they found the pathway helpful, you can click on the feedback button on the actual pathway, or you can write to our team to give us feedback on the pathways so that we can always try and make them better for you. That's the end of my very short part of today's presentation.
So, Martina, just to make sure, so people would search, so in the browser they put in Southeastern Sydney Health Pathways.
Yes.
And then they use those login details.
That's correct. Or I mean, today with this slide up, they can just use that QR code from their phone, and that will take their browser on their phone to the site, and then those login details, username SE Sydney and password healthcare.
Okay.
Or the web address there is also Allan, the sesydney.communityhealthpathways.org.
I think I want to. I should know the answer to this. Do we, on the pathways, is there anything that we can print out to give to the patient?
Yes, there's in the pathway down the bottom, there's 2 sections, for health professionals and for patients, and often the for patients section has some links to printouts or information. Sometimes we'll pepper through the pathways some links, external links that you can provide the patient. They're not extensive. We actually have a little health pathways rule that says that you should aim to have 3 or less links at the bottom in those sections, because we want to try and choose best in class, if you like, and link to those. But yes, you can always find information, extra information for yourself and information for patients down the bottom of the pathway. And just to use an example, in the COVID pathways, there's a lot of patient information about the medication that are actually linked in the pathway. So as part of the process, provide patient information, then it links to the Clinical Excellence Commission documents, for example. So, yeah.
There's just a question there.
And it's probably good that maybe Justin and I, because it's someone who's really good on exercise. So it's about they've got mild. Justin, do you want to do it, Justin?
For me, Alan, I'll start if it's okay. Firstly, a great talk and enjoyed it at all. I agree with pretty much everything you said. Maybe the only thing that I tend to use that is PRP. I'm not a believer in stem cells myself either, because I just don't think they've proven enough. I do like that as an option in non-swollen arthritic knees, but only as part of my armory, not as your first choice. So with this person, I again like the concept of activity modification, the concept of avoiding aggravating activities in general. So things that clearly cause more pain or swelling during, after, or the next morning, we modify or we avoid. That's the kind of advice I give. So sometimes it's about altering the type of exercise they do, or the time, the frequency, the intensity, the duration, or the total volume of their exercise. But if it's something they enjoy, then I think it's sometimes hard to say, oh, well, let's go swim or cycle. If that's not something they enjoy, they're not going to do it. So we need to maybe modify rather than cease completely. Sometimes it's about doing simple things like ice packing the knee afterwards to avoid any aggravation. I do like ice packs and Voltaren creams only because they have so few side effects. And even if they do, a minimal amount for pain, what have we lost? And we spare using the other agents that have side effects. So I would say modify activity, use the simple measures like ice packs and creams afterwards. Depending on the timing of when they exercise, they might even think about taking 2 Panadol, 2 hours before the exercise to cover them for that if it's something they enjoy.
Yep. Yeah. And I know the questioner was wondering, would it increase the rate of progression? And I don't think so. I mean, I think the studies, obviously a hard thing to randomize. You can never randomize 100 people to stop exercising and 100 to keep exercising. But I tell people that the balance, the function of their knee, that they're better off being very active. Whether it means what remaining cartilage lasts 5 years instead of 6, I don't know that we know for sure. But if I have so few patients who enjoy running on a treadmill. If I had one, I wouldn't stop them. I'd rejoice. Yeah, because I thought we don't want to make people.
I think it's got so many benefits, Alan.
Yeah, that's it, doesn't it? So many other benefits. Yeah,
like weight control, quality of life, enjoyment. It's. I mean, maybe only if it significantly increased their pain afterwards or made their knee swell, then maybe we'd think twice about is it increasing the progression? It's certainly increasing the symptoms. But I agree, it's very hard to know. I mean, everything we do is weight bearing in daily life anyway. We go upstairs, we walk to the shops, we do this. So again, if it's something they enjoy and it controls their weight, which helps their knee, I think it's worth trying to find a way for it to continue without increasing their symptoms.
You'd think that if they were getting pain after they were doing the exercise, they wouldn't enjoy it. So it's, it's more the fear that is it making it worse. But if they're able to do it and they're enjoying it.
My wife just loves swimming, and you know, she swims with women of a certain age, you know, and I saw one of them down there, and this poor one, she developed a frozen shoulder, and so she couldn't freestyle. So you know, she was swimming laps on her back, kind of like a fur seal, like on her back, and flapping her little hands in front of her, you know, to propel her. And I thought, she's going to do well, you know. She did. She's, you know, took a while, of course, frozen shoulders, but she got completely better. She's back swimming freestyle, and so person loves exercise. Very lucky, a blessing.
I'm not sure if you both wanted to just quickly talk about referral to, obviously, to your service at the hospital, Prof Sturgess, and to you as well, Justin, in the private sort of world, just for the GPs, or any contacts in the hospital, if there was any, for GPs to contact for further information about anything.
Sure. Yeah, so I'm actually on the, at St George, I'm on the sports medicine rotation, which is a pretty vague rotation because everything goes into orthopedics, but all my contact details are there with St George ED. But I'm at Cogra, so we're at Premier Orthopedics and Sports Medicine, almost opposite the private hospital. Pretty easy to find. You know, GP referrals are really what we need, and essentially, I guess the way to think about it is like any specialist, it's tertiary referral. So if you've got someone with a problem of a musculoskeletal nature, tendon, bone, joint, and they've tried the simple things, you know, a little bit of physio, some basic management of pain and function yourself, then that's the time to send along and a bit more specialist exercise and sometimes injections depending on the symptoms.
Yeah, I 100% agree. The often in my position, often all I'm doing is confirming that the diagnosis that the family doctor's already given the patient is correct, and emphasising, yes, look, what doctor said is right. You know, you got to lose some weight. Obviously, nobody can lose. Human beings can't lose 30 kilos, but you lose 5% of the extra weight you've got. It'll make a big difference to your knees. Do the exercises like your doctors explained to you. Yep. So that's often my relatively small role. I mean, I wish I had drugs like methotrexate, you know, and Enbrel and biologics, but we just haven't got those for osteoarthritis yet.
Thank you so much, Associate Professor Sturgess and Associate Professor Paolono. Thank you so much for joining us this morning. We really appreciate it. Thank you and have a good day.
Bye.